Deepak is the Executive Director of Interventional Cardiovascular Programs at Brigham and Women's, and he's a professor of medicine at Harvard Medical School. I've known Deepak from the time he was a fellow and I was an intern at Cleveland Clinic. And it has been amazing. It was amazing then, and it's amazing now to see his energy and productivity. Deepak's research interests include ACS, preventive cardiology, advanced techniques in cardiac, cerebral, peripheral interventions. His work has covered pharmacotherapy to the newest devices that are being evaluated in different fields. So he has, every time I think about what has Deepak done, he has published 1,500 papers. I suspect that was a few weeks ago. Now it'll be 1,600 papers. And he's been listed on the Web of Science group as a highly cited researcher from 2014 to 2019. He has been the PI or co-PI of some of the largest randomized clinical trials in cardiology, starting with Charisma. And, just to give just to put this in a context, he was the first author on 2 papers in NEJM last issue. That is probably not many people on this planet who've reached that level of research greatness that Deepak has. He's been listed in the best doctors in America from 2005 to 2020. He is also a great teacher and a mentor. He received the Eugene Braunwald Teaching Award for Excellence in Teaching Clinical Cardiology from Brigham and Women's in 2017, and ACC's Distinguished Mentor Award in 2018, and AHA Distinguished Scientist Award in 2019. And beyond all that he's done professionally, I've known Deepak personally. He's a wonderful person, and he's got a wicked sense of humor. It's a great pleasure and a privilege to welcome Deepak to BMC2, and he's going to be talking on post-PCI medical management.
Well, great. Well, thank you so much for that really kind and warm introduction. If I'd known it'd be that good, I would have had my mother join us for this Zoom call. But really, thank you. And it's great to see how successful you've been in general at U of M, but in particular with this collaborative project here in BMC2. It's just terrific just seeing everyone come together in the role you've played in disseminating the knowledge from this and the word about its existence. I think you told me about it first a couple of years ago, and I was quite impressed then and have become really even more enthralled with the great work all of you are doing up there in Michigan. So let me go ahead and get started with my talk tonight. I know it's late for everyone and probably everyone's had a long day. I was asked to speak about post-PCI medical management. And of course, there are a lot of things that one could talk about, but I'm going to just focus on a few specific aspects of that. So let me go ahead and get started with things. Before launching into my talk, here are my disclosures and ones that are relevant in particular to tonight's talk, perhaps, since I'll be covering data from Themis as research funding from AstraZeneca that goes to Brigham and Women's Hospital, since I'll be covering ODYSSEY, research funding from Sanofi Aventis that goes to Brigham and Women's Hospital as well for the work I've done on that trial. And since I'll be covering triglycerides research that I've done on the REDUCE-IT trial with funding from Amarin, again to Brigham and Women's Hospital. And through the course of the talk and any Q&A, I may be discussing things that are off-label or investigational with respect to drugs or potentially devices. I was asked to talk about the post-PCI medical management, and I think it's worthwhile to reflect on the European Society of Cardiology and what they did in their guidelines in 2019. I thought it was clever. Maybe everyone doesn't like the semantic change, but they introduced this concept of chronic coronary syndromes into the guideline. Everybody knows about acute coronary syndromes. It's what we spend a lot of the time in the cath lab treating. But what they were talking about is that stage of disease after or potentially before an acute coronary syndrome. So at some point, everyone that ends up in the cath lab is having some sort of acute event, either an ACS or some worsening angina that provoked a stent implantation. But after that acute coronary syndrome or acute revascularization event, they then have a chronic disease and a chronic coronary syndrome. I think it's useful to think of it that way. Sometimes patients, perhaps more so than doctors, think that they're cured after their procedure. And indeed, stenting and PCI are highly effective for treatment of angina and saving lives, and also reducing myocardial infarction in the context of ACS. So there's utility of stenting across the full spectrum, whether it's symptom control or MI and death reduction. But it's important for the patients to realize that their journey has just begun, so to speak, and they do need to do things like stop smoking if they're smoking. If their spouse is smoking, that person needs to stop and get that second-hand smoke out of the house. If there is a diet that's bad, that needs to be changed. If they've got the couch potato syndrome where they're not exercising, and that's become rampant in the COVID era, well, then they need to get out there and exercise, maybe with the help of a cardiac rehabilitation program. So there's a lot to do, and patients are part of that, but we've definitely got to encourage them and try to create an infrastructure for that care. Beyond all that, then, there is medical therapy, and we play an enormous role in that. And those of us involved in procedural care or catheterization laboratory-based care, it's important to realize that that post-procedural long-term care is our philosophical responsibility. Now, we might do it ourselves or we might delegate it, but we've got to make sure somebody in our system is doing that. Now, let me focus on the first of those three areas that I said I would discuss this evening, and that has to do with antiplatelet therapy and its role in long-term care of the post-PCI patient. Everybody on this call, of course, knows the central role of platelet activation and aggregation in acute coronary syndromes and in acute revascularization and in the chronic term. That's extremely well known. And the ADP receptor in particular plays a pivotal role there. And agents such as clopidogrel, Prasugrel, Ticagrelor have really revolutionized cardiology and interventional cardiology. Probably not too many people on the call remember the days of, say, ticlopidine and the challenges with that, loading patients on the table, patients vomiting on the table, and the ticlopidine coming right back up, issues with having to monitor the white count, or the era before that with aspirin, warfarin, heparin, dextran, really some messy times in terms of bleeding and other complications and stent thrombosis. So we've come a long way since then with pharmacotherapy, and sure, stents have also gotten thinner with better drugs and polymers and deployment techniques and ancillary imaging and all of that. That certainly has helped, but the medications have been part and parcel of that evolution. Well, let's go back a little bit in time to PCI cure. This was the sub-study from the overall cure trial that put dual antiplatelet therapy on the map for acute coronary syndrome. And in those patients with PCI, well, they did really well if they were on a year of DAPT versus a month of DAPT. And this is the bare metal stent era, but these weren't largely stent thromboses that were being prevented. These were other events. So CV death or MI significantly reduced, a 3% absolute risk reduction, a 31% relative risk reduction for a year versus a month of dual antiplatelet therapy. And I'm not sure that things have changed dramatically if this trial were to be redone. I mean, the stents are better, so whatever contribution of this was due to stent thrombosis, that would go down. But the risk for spontaneous MI might have gone down some since that time, more use of statins at high intensity, other sorts of ancillary medical therapies. But I think this old evidence is still pretty good that in the ACS patient who's had spontaneous plaque rupture, longer durations of DAPT are better than shorter durations of DAPT. Now, if you start comparing 6 months to 12 months in a few thousand patients, or 3 months to 12 months, then it may not be such a contrast and it may not be so evident, but that's why I wanted to prevent the contrast of 1 versus 12 months. And that was ACS. This is Credo, done around the same time, largely elective PCI, although there were some stabilized ACS in here too. So it was a little bit of a hodgepodge of elective and stabilized urgent type patients, but same sort of thing, that a year was better than a month, the same sort of about 3%, around 30% absolute and relative respective risk reductions. So very consistent data from that era. And the biggest risk of bleeding, of course, is GI bleeding. And as it turns out, if we've got patients on DAPT and long-term DAPT or even short-term DAPT, if we're worried about major bleeding, well, GI bleeding's at the top of that list in terms of frequency. Of course, intracranial bleeding is the bleeding we worry about the absolute most, but fortunately, that is infrequent with DAPT. It occurs, but much less frequently than GI bleeding. And as it turns out, in the COGENT trial, we learned that a proton pump inhibitor significantly can reduce the risk of GI bleeding. And in COGENT, these were low GI bleeding risk patients, not high GI bleeding risk patients, even though the guidelines really focus on high GI bleeding. So the point being, if proton pump inhibitors worked this well in patients at low GI bleeding risk, well, then presumably they'd work really well in patients at high GI bleeding risk. Let's move from clopidogrel to prasugrel now, a more potent version of clopidogrel, more efficiently metabolized and really delivering more active metabolite to the ADP receptor on the platelet. It was studied in Triton, and it was an advance where it showed overall a positive trial, but in particular in patients who were not underweight, who were not over the age of 75, who didn't have a prior stroke or TIA. And that type of idealized patient, it was clearly superior to clopidogrel to be on prasugrel with not only better efficacy, but better net clinical benefit. That is lumping together both ischemic and bleeding events. So more potent was better. But in the wrong patients, such as those with prior stroke or TIA shown here in red, there the entire strategy backfired. And this has been a consistent theme in patients at really high bleeding risk, intensifying their antithrombotic regimen, lengthening it in terms of duration seems to backfire. So if a patient's at high bleeding risk, these strategies almost never work. And it's the challenge really between balancing between a rock and a hard place, so to speak, Solon and Charybdis. That is, more antithrombotic therapy for longer in general is good and reduces rates of myocardial infarction, in some cases stroke, depending on the circumstance, stent thrombosis, but always increases bleeding, occasionally bad bleeding, and frequently fatal bleeding. All right, well, after that, next in the series of antiplatelets came Ticagrelor. And this is also a more potent version of clopidogrel, but a bit different from prasugrel and clopidogrel. Those are irreversible antiplatelet agents. This is a reversible agent. Does that matter? Well, in some respects, it might. And if you were trying to get a patient to surgery sooner, the ticagrelor washes out of the system in about 3 days versus about 5 on average with clopidogrel, with pretty wide confidence intervals due to variability in that drug's response. And then prasugrel is about 7 days. So potentially some advantages here if you needed to go to cardiac surgery or maybe even remove a gallbladder or something like that. But of course, if a patient needs emergent surgery, then it's not out of the system immediately. The data for ticagrelor really come from PLATO, where it was found in ACS to be superior to clopidogrel. Pretty large reduction here, I think, 16% in relative terms, about 2% in absolute terms for cardiovascular death, MI, or stroke, hard events. And this is ticagrelor versus clopidogrel. You can imagine placebo, if we had cure and PCI cure, would be up here at the top. So if this were placebo versus ticagrelor, it would be an enormous risk reduction. And it's important to realize these data because there's been some degree of controversy injected by trials like ISAR REACT 5, where it looked like ticagrelor was inferior to prasugrel. It doesn't really make sense if ticagrelor is this much superior to clopidogrel here, why, and the degree of benefit of prasugrel over clopidogrel was similar in relative and absolute terms. How then, when you compare the two of them directly, is one so much better? Doesn't totally make sense. Here are individual endpoints from PLATO, and the reduction in MI has been seen in most trials of dual antiplatelet therapy. But what was interesting and distinguishing is this reduction in cardiovascular death that was significant in the PLATO trial for ticagrelor versus clopidogrel. And that's why at least some folks, myself included, do tend to favor ticagrelor, even though it's more expensive than clopidogrel right now, because of this reduction in cardiovascular death. Well, bleeding, though, was increased with the more potent agent. That's not surprising if one looks at non-CABG bleeding. But interestingly, CABG-related bleeding wasn't increased. And that might have to do with what I was talking about, that reversible nature, such that if you stop the ticagrelor and wait a few days, that washes out of the system faster than clopidogrel would on average. And one thing I'll mention for interest, this is something that's not available are these phase 1 data. So phase 1 means healthy human volunteer data published in New England Journal of Medicine a little over a year ago that looked at a monoclonal antibody that reverses ticagrelor. And for the sake of time, I won't go through all the curves here, but what the interpretation here is that it essentially immediately and completely reverses ticagrelor's effect as it's being infused. So a monoclonal antibody specific to ticagrelor wouldn't work with irreversible agents such as Prasugrel or Clopidogrel, or for that matter, even aspirin. It would only work for ticagrelor. But we just have launched the phase 3 trial in actual patients with bleeding or undergoing urgent or emergent surgery. That this was healthy human volunteers. But hopefully it will behave as it did here, and if it does, potentially then it will hopefully be on a pathway to approval. Has been designated with breakthrough status by the FDA. So that means if things go well, it's on an expedited pathway. So potentially that bleeding hazard associated with dual antiplatelet therapy or with ADP receptor antagonists, even in monotherapy, could be decreased by this sort of agent if it were available. All right, let me move now from the ACS setting to more chronic settings. And these are some data from the Charisma trial. Secondary prevention and primary prevention hybrid trial, overall not showing a significant benefit for the primary endpoint of DAPT versus aspirin, but in the large subgroup of stable CAD or CVD or PAD, there was a significant reduction, whereas in the primary prevention subgroup, there was no benefit and in fact only a bleeding hazard. So it did seem like the secondary prevention patients might be benefiting. That was the primary endpoint. If we looked at the secondary endpoint that included not just CV, death, MI, or stroke, but softer events, I'll say, like revascularization and rehospitalization for ischemic events, there the overall trial was in fact positive. And another thing that is not commonly appreciated is that stroke was reduced in the overall trial with a strategy of DAPT. And going now into some subgroup analyses here, looking at higher risk patients from Charisma, such as those with prior MI, perhaps most relevant to this audience, there was a significant reduction in ischemic events with clopidogrel plus aspirin versus aspirin alone. Now, the data are subgroup data of an overall trial that missed its primary endpoint, so lots of caveats. But it's interesting, if one looks at worldwide registry data, about 50 to 60% of patients 2 years after their MI, STEMI or NSTEMI, are on clopidogrel and aspirin. So the data did end up influencing practice, even if the impact in terms of labeling was relatively minor. At any rate, Charisma led then to a prospective evaluation of that subgroup finding in Pegasus, where we took 21,000 patients with a history of MI 1 to 3 years prior, plus an additional atherothrombotic risk factor, and randomized them to placebo or the ACS dose of ticagrelor or an in-between dose of ticagrelor of 60 BID, all on top of aspirin. And the primary endpoint was met, a significant reduction in that triple ischemic endpoint with both doses of ticagrelor, although the FDA approved the 60 milligram BID, given that it had somewhat less bleeding and somewhat less dyspnea, another side effect of ticagrelor. And if one looks at individual endpoints, CV death trended with a p-value of 0.06 to being lower with the combo versus aspirin alone. Myocardial infarction was very significantly reduced, and stroke, interestingly, as we saw in Charisma, was also significantly reduced in this CAD population or high-risk CAD population. Now, if we look at some other subgroups from Pegasus, one that is of general interest is those patients with diabetes. First, let's start with those without diabetes. There was a significant benefit in the primary endpoint. And in those with diabetes, also a significant benefit, but due to their higher baseline risk, a larger absolute risk reduction was seen in those patients with diabetes from Pegasus. Again, all of the patients had a history of prior MI 1 to 3 years ago. And now if we look at fatal myocardial infarction, that's what coronary death means, there are no significant difference in those without diabetes, but in those with diabetes, a significant difference, showing that in the highest risk post-MI patients, diabetes plus the being post-MI, not only is it non-fatal MI and non-fatal stroke being reduced, but even fatal MI is being reduced. Another subgroup of interest are those patients with PAD. And here again, we see in those with and without PAD, a consistent benefit, but because of their higher baseline risk, those with PAD, much like those with diabetes, derive a larger absolute risk reduction. Also, I'll point out, I mentioned the reduction in MI and stroke, which of course is ischemic stroke, though I was referring to all-cause stroke in that slide. There was also a significant reduction in major adverse limb events with dual antiplatelet therapy versus aspirin alone. This isn't as commonly appreciated, but a significant reduction in major adverse limb events. Now, the frequency in this post-MI population is pretty low. You know, the percentages here are quite low, under 1%, but still a significant benefit that one would like to think would be amplified if patients were at even higher risk. Okay, those are some trials. Let me just move through quickly some meta-analyses looking at long-term DAPT in patients with a prior history of ACS, either unstable angina or non-STEMI or STEMI. And the overall message is here. The primary endpoint of these trials, including patients from Charisma, Pegasus that I reviewed, other trials I didn't review for the sake of time. It's a consistent story. Overall, when we look at 30,000 plus patients, about a 22% relative risk reduction, about a 1.1% absolute risk reduction in the triple ischemic endpoint, statistically significant. So really, this proves what the benefit is of long-term DAPT versus aspirin in patients with a history of previous ACS. And I should say the results were consistent in those treated with stents and in those just treated medically for their ACS. So this isn't a stent or stent thrombosis story. This is a plaque rupture and underlying thrombotic risk story. As well, in this pooled analysis, cardiovascular death was significantly reduced, a 15% relative risk reduction. In absolute terms, a 0.3% absolute risk reduction. So modest in absolute terms for sure. And you need to keep that in mind in weighing the decision on whether to use long-term DAPT or not. Again, it can backfire if the bleeding risk is high. Speaking of which, there's a significant excess in bleeding, a 73% excess in major bleeding, 0.8% absolute risk that's statistically significant. Fortunately, in the context of these particular trials with careful patient selection, no significant excess in fatal or intracranial bleeding, though of course those can occur in real life. And there's been a lot of talk about shortening DAPT these days, and that may be appropriate in elective settings. But in ACS, I would point you to the SMART DATE trial out of Korea, where when they dropped DAPT durations to less than or equal to 6 months, there was a 5-fold excess of myocardial infarction versus longer durations of DAPT. So I'd still say the default position in ACS, even with the most recent data, generally speaking, supports longer duration DAPT unless patients are at very high bleeding risk. Let me move on now to the THEMIS study. This has nothing to do with ACS. This is the largest trial of diabetes ever done, 19,000 patients. I don't mean the largest in the antithrombotic world, I mean the largest period. So 19,000 patients with diabetes, stable coronary artery disease, greater than or 50%, greater than or equal to 50% angiographic stenosis, who were then randomized to Ticagrelor plus aspirin versus aspirin alone, or aspirin plus placebo. There were the patients, if they had a history of myocardial infarction or known history of stroke, were excluded. So these weren't ACS or MI patients. These were patients with stable CAD. And the overall trial was positive. There was a 10% relative risk reduction, about a 0.7% absolute risk reduction. So a modest benefit, but significant in this overall broad population. And looking at bleeding, there was a significant excess, about a 2 to 2.5-fold hazard ratio for an increase in major bleeding. So that's not trivial. And intracranial hemorrhage itself was slightly but significantly increased from 0.5 to 0.7%. And this just shows you that you really need large numbers of patients to see that signal with DAPT. We'd seen that in the meta-analysis of all the trials of clopidogrel, where there were significant increases in intracranial and fatal bleeding, but we needed, I think it was close to 100,000 patients to see that. But here, the increase in intracranial hemorrhage largely was traumatic subdural hematomas. I think there's an important message there. presume many of us counsel patients on warfarin or NOACs, to wear a helmet when they're biking. I mean, obviously you should do that anyway, but to make sure they're wearing a helmet when they're biking or skiing, avoid ladders, wear your seatbelt, the usual stuff that probably everyone should be told, but I think we go out of our way to tell that to patients on warfarin and NOAC. I think the same advice should actually be given to patients on DAPT because it does increase that risk of, especially traumatic subdurals. It takes a lot of patience to see it, but it's there. Now, one issue with antithrombotic therapy, it's true of every therapy, statins, everything is patients can discontinue. That happens. But here there was a 10% or so excess discontinuation. So first of all, in the placebo arm, you can see 24% or a quarter of the patients discontinued placebo due to side effects. So that really tells you something about the nocebo effect. But at any rate, there was an actual 10% excess rate of discontinuation. Of this, 2/3 of it was dyspnea. You might have thought it'd be bleeding, but 2/3 of that was dyspnea and 1/3 of it was due to bleeding. So these are both known side effects. But if you do what's called an on-treatment analysis, looking at patients who didn't stop because of dyspnea, didn't stop because of a bleeding complication, and were just otherwise generally adherent to therapy, so you could say good patients, well, in that sort of idealized circumstance, the relative and absolute risk reductions and robustness here really become more marked. Now, obviously, biases can creep in when one does an on-treatment analysis. It's an idealized situation, but still, it shows the potential value of DAPT in more carefully selected patients than just in the trial overall. All right, that was overall THEMIS. THEMIS PCI is that pre-specified subgroup from THEMIS, about 11,000 patients or so with diabetes and a history of prior PCI in the past. It's the largest cohort of diabetes plus PCI in a trial to date. And what we did here was look at the same endpoints, and what it turned out to be the case, the overall trial, it was positive for the primary endpoint, significant reductions in MI and stroke and peripheral ischemic events as well. But here it looked like really the bulk of the action was in patients with a history of prior PCI, more so than those without prior PCI. And for the sake of time, I'm not going to walk through this table, but it seemed like essentially you get more bang for your buck in the patients with a history of PCI. And the same was true in terms of bleeding, a little less bleeding in those folks, maybe because they'd all been on DAPT before and not had a problem. So a little bit better patients for prolonged or continued DAPT. The on-treatment analysis here as well looked better than the intention to treat analysis. And in fact, for all-cause death, you'll see that there was even a significant, nominally significant reduction in those getting DAPT who had a history of PCI versus getting aspirin alone for long-term therapy. One other thing I'll point out from THEMIS PCI before moving on is this curve here where we showed for the first time in a randomized trial just how long the benefit of DAPT continues. So nobody's doing randomized trials of DAPT for 10 years. Nobody's doing randomized trials of anything for 10 years for the most part. But here we have patients where they had their procedure, their index procedure in this definition of prior PCI, up to 10 or more years before. Now, of course, when we're talking about 8, 9, 10 years, there's fewer patients. But out till about 6 to 7 years post-PCI, we see there was still a benefit of dual antiplatelet therapy. The hazard ratio and the dotted lines, or the 95% confidence interval, are under unity up till about 6 to 7 years. And after that, again, the number of events gets kind of low. But the hazard ratio directionally, the dark line, is still under 1, even out to 10 years. The confidence interval is broadened. So I think this shows, first of all, the benefit of DAPT is greater the closer you are to the event. That's already known. But it does persist, I think, much longer than most of us appreciated. And the LIM outcomes were just presented by Mark Banaka as a late breaker at ESC. Haven't published it yet, but much like I said, there was a reduction in MI and stroke in the overall trial. There was also a significant reduction in peripheral ischemic events in the overall trial. Now that's THEMIS and THEMIS PCI. That's really advocating for longer durations of DAPT than are currently the standard in that population. Here's the TWILIGHT trial, and in a sense that argues the opposite. So these are patients that are high-risk PCI patients, including ACS patients. Everybody is first on a period of DAPT for 3 months, aspirin, Ticagrelor specifically, if they had a bad ischemic event or a bad bleeding event. then they're not going to be in the actual randomized part of the trial. But for those that passed those filters, they were then randomized to essentially continue ticagrelor and aspirin, or just continue ticagrelor and placebo. So really, it's a randomization, you could say, of aspirin versus placebo on a background of ticagrelor. So can you drop aspirin at 3 months? And as it turned out, for their primary bleeding endpoint, there was a significant reduction in major bleeding. And actually, I'm showing the BARC 3 or 5 bleeding, which is a bit more precise even, a 50% reduction, 2% to 1%. So, you know, that really is, I think, a believable finding that there'd be less bleeding by dropping aspirin. But I think it's an important finding. Excuse me. And, you know, it's a message I think that many of us that are in the cath lab like to hear, because we don't like bleeding, and reducing it is in general a good thing. Now, the question though is, okay, bleeding is reduced, but is there a price to pay? And as it turns out, there wasn't. And subsequent analyses of their complex PCI and diabetes subgroups also did not show any difference. So that's a bit surprising, I suppose, but patients did pretty well here. But realize this is essentially comparing 3 to 12 months of DAPT, you could say, and it doesn't compare 3 to, say, 24 in people who tolerated out to 12 months. So it doesn't actually refute any of the longer term DAPT, and it provides an option for those patients that are at high bleeding risk, not that they were necessarily high bleeding risk in this trial, but certainly the data can comfortably be extrapolated to the high bleeding risk patient. Now, if you find it useful to use risk scores, there are several of them out there. There's the DAPT score, the PARA score. I've chosen to show precise DAPT is published in the Lancet. And here, this one, I like it because it's easier to remember what goes into it. To calculate it, you have to use a nomogram. You can't do that in your head. But I like it because it mentions things that I think are really associated with bleeding. Now, elevated white count is just a proxy for sick patient, but age and creatinine clearance, for sure, that raises the risk of bleeding. Dr. Gurm's done a lot of work on creatinine clearance, and you know, it's a predictor of bleeding. It's also a predictor of ischemic events as is age. That makes life tricky because you know, you might want to decrease bleeding and therefore think, okay, less is better with respect to antithrombotic therapy. But as one gets older, creatinine clearance drops, so does the thrombotic risk. So those are a little bit tricky. But the hemoglobin, that is anemia, and prior bleeding history, those are great because those predict bleeding. And that's what really we want to do with a bleeding risk score. And there, in general, if a patient has anemia or thrombocytopenia or a history of prior bleeding, I think twice before strategies of either intensifying their antithrombotic regimen or lengthening it beyond the minimum duration. So here is another way of risk stratifying. That prior slide was a formal risk score. This is looking at angiographic risk factors, and the more there are, the more likely the patients to benefit from long-term DAPT. And this isn't, again, a stent thrombosis story so much. It's rather that the patient that needed a bifurcation left main stent has a lot of plaque in their coronary arteries and elsewhere in the body and are more likely to benefit for longer-term DAPT. Some of it may also be a stent thrombosis story. So what then is the optimal duration of DAPT? That's a tough one. I think there's no right answer that is universal. It depends on the patient. And in general, for ACS patients, I go longer. In general, for stable CAD, I go shorter. And the anatomy matters too. Short lesion, single vessel disease, you know, I feel comfortable with 6 months, or if they're at higher bleeding risk, 3 months. And if they're at super high bleeding risk, even a month, as some registry data recently have shown us. So it really depends on the patient-related factors, the anatomy factors, and the stent factors too. If it's some really complex stenting, bifurcation stenting issues with maybe the stent's not so well opposed in some areas, you know, there I might go longer. And I don't know how many people know this because it happened during the pandemic. The flow of information has been a little bit disrupted, but here are the labeling and approval for all the different ADP receptor antagonists for ACS and PCI. They're all approved for ACS medical therapy, clopidogrel and ticagrelor, for prior MI, clopidogrel and ticagrelor. But then what happened in June was based on THEMIS and THEMIS PCI, the FDA approved ticagrelor rather broadly, not just in those with diabetes as we studied, but any high-risk CAD patients, and I think it was legitimate to extrapolate, in order to reduce the risk of a first MI or stroke in patients with coronary artery disease at high risk for such events. And even though this label wasn't stent specific or not, it certainly can apply to patients who are stented. So something to be aware of. And again, this isn't a strategy for everybody. There's a bleeding risk. Obviously, there's a financial cost. But for select high-risk patients, this is now, I think, not only a good option based on evidence, but an option that falls within the label. And this is a meta-analysis that just came out in the last month that really goes into all the contemporary data, the short-term DAPT trials, the long-term DAPT trials, and in general concludes, yeah, for elective PCI, short DAPT, perhaps de-escalation to a monotherapy with an ADP receptor antagonist at 3 months is the way to go. But for ACS patients, probably longer is better to go, is what this meta-analysis in our data show. So to conclude about this aspect, and then I'll briefly touch upon a couple of others, the ACS patient, generally speaking, should still get at least 12 months of DAPT if there's no bleeding. If they're at high bleeding risk post-PCI, you can abbreviate that to 3 months. And at that point, I would say Ticagrelor is preferred based on TWILIGHT, but there are trials that I didn't review for the sake of time with clopidogrel monotherapy as well, largely from the Far East, and it appears to be also a good option. And in the post-MI patient based on Pegasus, in those with diabetes based on Themis, in those with complex stenting or complex coronary artery disease, which would fall under the Themis label, even if we didn't study those without diabetes per se, there you might consider longer durations. And again, it needs to be done with some wisdom and thought because there is a bleeding risk that can occur. Well, let me move now to lipid-lowering therapy and just touch upon a couple of things in the next few minutes before wrapping up. So hopefully you're all familiar with these concepts. I know of secondary and primary prevention. Important to think of primordial prevention as well, maybe not so much in our roles in the cath lab, but as physicians and public health advocates. And primordial prevention refers to really preventing the development of risk factors in the first place. And that's largely through lifestyle modification efforts. As far as lipids go, that's important for us in the cath lab. I remember when I arrived at Cleveland Clinic, and I see Stan Chikuti here, so he can fact check me if this is untrue. But when I arrived at Cleveland Clinic, I remember being told by the cardiac surgery fellows and PAs, that the patients needed to go out on a high-fat diet so that their sternal wounds could heal. But I think we've come a long way since then from not only not avoiding that high fatty diet and high cholesterol diet to recommending in general, plant-based whole food diets, to making sure that our patients go out on appropriate lipid-lowering therapy. And in many parts of the country, that's a quality metric that's publicly reported. I know it is here in Massachusetts. So of course, we've got to send them out on a statin. I think pretty much everyone's doing that in patients that don't have contraindications. But I'd say don't forget about ezetimibe. It also reduces cholesterol on top of statins. It does so safely. It's generic now. And it provides a modest but real incremental reduction in cardiovascular events. So it's something that I think should be in our toolkit. As well, the PCSK9 inhibitors have been shown to be effective beyond oral therapy. These are data from Fourier showing a significant reduction in ischemic events. ODYSSEY as well, large reductions in LDL cholesterol, large reductions, I would say, in ischemic events if one is treating patients long-term. The duration here in both these trials, relatively modest duration, but still important reductions in important ischemic events. And in fact, in ODYSSEY, which as you recall was an ACS trial, patients were enrolled 1 to 12 months after their ACS, there the benefits seemed a bit larger when one looked at things like death. And one can dispute the p-values here. There were some issues in terms of the hierarchy and so forth, but overall it looked like there was a real story here where that patients that had higher degrees of LDL, such as greater than 100 milligrams per deciliter at baseline, despite their statin therapy, not only were there reductions in non-fatal ischemic events, there seemed to be reductions in all-cause mortality. So just to caution, this is a post-hoc analysis, but nonetheless, it looked like a real finding. The higher the LDL cholesterol, the greater the benefit on heart events, even over this relatively short 3 to 4 year duration. And in fact, a cost effectiveness analysis, something I published in JACC, it was this greater than 100 milligram per deciliter subgroup where the drug was most cost effective, even at its current somewhat high price. And this is something from an editorial just a couple of weeks ago with Mike Shapiro, preventive cardiologist, where we were talking about cholesterol years. We were talking about PAC years a little bit earlier with smoking and that sort of thing. Well, these are cholesterol years. And it's important to think about not just the level of LDL cholesterol, but how long has it been going on unchecked? Because the longer it's been happening, well, the plaque is forming, including potentially vulnerable plaque. So really got to think about much earlier treatment of LDL cholesterol for sure by lifestyle modification, but in many cases in obviously secondary prevention, but also primary prevention, that's high risk primary prevention. Now let me just move a little bit to talk about triglycerides as a target for therapy. There are lots of therapies that are existent and coming down the pike for hypertriglyceridemia. Some of the most exciting are approaches of targeting RNA that can lower triglyceride by 50%, 100%, enormous reductions in triglycerides. So if lowering triglycerides per se reduces cardiovascular risk, this series of trials should prove or disprove it. And this is just from a couple of weeks ago. There's a revolution going on in omega-3 fatty acid research right now. All sorts of different omega-3 fatty acid compounds that are being studied by a variety of scientists and companies throughout the world. So I think we're going to learn a lot about it. Yes, there are natural sources of omega-3 fatty acids, but in general, humans are pretty inefficient at going through these multiple enzymatic steps to produce the omega-3 fatty acids that seem to be most beneficial in health. The story for omega-3 fatty acids is strongest for EPA or icosapentaenoic acid. It starts with the JELIS trial, a study of 18,000 patients in Japan that showed significant reductions in cardiovascular events with EPA or icosapentaenoic acid versus control. Open label design, no placebo, but randomized positive trial. Majority of patients are primary prevention, a 19% relative risk reduction. And consistent benefits in the primary and secondary prevention cohorts in this large, well-done study from a few years ago. There was an accompanying intravascular ultrasound study for those of you in the audience that are fans of IBUS. And here, the study called CHERRY randomized patients to 1.8 grams a day of icosapent-ethyl or a purified EPA versus none. Again, open label, but randomized. And everybody was getting pitavastatin, so a good statin, reasonably effective at that dose, 193 post-PCI patients. And what they found was regression in both arms, the statin monotherapy and the EPA plus statin, but more regression in the EPA plus statin arm. So a significantly larger degree of plaque regression by IBUS by only 6 to 8 months, a pretty early effect here of a medium dose of icosapent-ethyl in these Japanese patients who of course have higher baseline EPA than Western patients. And then came the REDUCE-IT trial where we also studied icosapent-ethyl, the same active ingredient as JELIS, but a higher dose, 4 grams a day in a Western population with lower baseline levels, and found significant reductions in MACE, either including softer endpoints or hard endpoints alone. And more recently presented as a late breaker at SCAI with an updated TCT presented by my interventional fellow, Ben Peterson, was REDUCE-IT REVASC, perhaps particularly relevant to this audience tonight. And what that study or analysis found of the overall study was a significant reduction in coronary revascularization with icosapent-ethyl versus placebo. Large relative and absolute risk reductions in this blinded trial with independent adjudication of the endpoints blindly adjudicated by Mike Gibson's group here in town. And the independent predictors of revascularization, well, the beneficial one that emerged was icosapent-ethyl versus placebo, 36% relative risk reduction. But the negative predictors were history of prior PCI, male sex, diabetes, so none of that is particularly novel. But interestingly, triglycerides and CRP were both predictors of increased revascularization risk down the road. When did the benefit kick in? Well, it turned out this revascularization reduction was significant, statistically significant by 11 months. It was directionally lower right from the get-go, but became statistically significant by 11 months. So this is in keeping with what was seen in CHERRY, where they saw effects on plaque by 6 to 8 months in that open label trial. So here are the evaporated results, the interim results, same drug that we used in REDUCE-IT and in CHERRY and JELIS, but the 4 gram a day dose. And here we see several measures of plaque volume and composition favorably affected by 9 months. And then by 18 months, even more significant in terms of the number of different types of plaque volume and composition measures that were influenced. So this study, which used non-invasive CT angiography, basically found the same things at 9 and 18 months that Cherry did at 6 to 8 months with IVUS. So really two sets of trials, JELIS with a mechanistic study, Cherry, at 1.8 grams a day of icosapent ethyl versus none, and the evaporate and reduce it trials using 4 grams a day of icosapent ethyl versus a matching placebo, similar sort of message. Let's get back now to reduce it revasc, where we saw significant reductions in elective, urgent, and even emergent coronary revascularization. In this blinded trial, it was significantly reduced. Time to PCI was significantly reduced. Maybe that's bad for business, but that's what the data show. And also a significant reduction in CABG in a blinded trial with independent adjudication of endpoints. So that's pretty unusual. Really, relatively few things have seen reductions or shown reductions in CABG as an endpoint. And how does this compare historically to trials of medical therapy? I threw a Norstent in here too. Well, really not since the 4S trial, that is going back to the pre-statin era, statin versus placebo, have we seen this type of reduction in revascularization. And of course, in Reduce It, by protocol, everyone was on statin. So this is incremental to whatever would have been going on in the 4S trial, which was statin versus placebo. So finally, then, just to conclude, these are 3 different axes to consider in terms of risk reduction. The thrombotic axis with dual antiplatelet therapy in carefully selected patients, the LDL lowering axis pretty much in everybody, and in patients with elevated triglycerides, the icosapent ethyl axis. And I've focused really on higher risk patients in secondary and tertiary prevention, high risk primary prevention in some cases. But really, I think as interventional cardiologists, all these domains are ones that we've got to be comfortable with, because we're often called upon to deal with either the antithrombotic regimen or lipid-lowering regimens of these patients. Well, thank you very much for your attention. I tried to stay on time so that there'd be ample opportunity for questions if there are any. Let me once again thank you all for the invitation to speak and congratulate you all on what you've accomplished with BMC2.
So thank you so much, Deepak, for that wonderful talk. We have a few questions. If you can, please use Q&A for questions and not chat, but I'm going to read them. So one question is your thoughts on identifying and treating active vulnerable plaque in addition to culprit lesion during index PCI.
Well, that's a great question. There are modalities that seem to be increasingly accurate for identifying plaque with features that have associations with vulnerability in future events, thin cap fiber atheronoma. There are all sorts of things, virtual histology, OCT. And I think these technologies are great from a research perspective. In terms of clinical use, there needs to be a phase 2 of these trials where we look at randomizing patients with plaque that's assessed as vulnerable, either through invasive or non-invasive imaging, and then randomize them to different therapies and see if it makes a difference, whether those therapies are stent-based or whether those therapies are drug-based. Future trials will have to say. So I think it's a really interesting area of research. My own prediction, though, is, vulnerable plaque tends to be all over the place. If it's in the right coronary artery, it's probably in the left coronary artery. If it's in the left coronary artery, it's probably also in the left vertebral. So, I tend to think that a systematic approach or a systemic approach with, obviously lifestyle modification, if it's intense enough, that can be really terrific. But then, systemic medical therapy is probably ultimately going to, be what prevails. But, there might be high risk ACS patients that come in where such imaging in the future, maybe in the setting of an NSTEMI could be really useful, because in general, we go after, what looks like that hazy, 80% prox RCA lesion, but it could be that 50, 60% lesion in the mid LAD, which we're not going to stent, and maybe it's even IFR negative, maybe that should be stented, and maybe future studies will show it, but we would really need future studies for that.
So, a couple of questions related to cost. So the question is, would you consider Prasugrel as your preferred agent over Ticagrelor because it's now generic?
Well, that goes beyond what I would prefer, because right now in Massachusetts, we're getting a lot of calls saying, hey, Prasugrel is now preferred in this patient's, insurance tier. So you've got to use it. Is there a good reason not to? So, In fact, that's happening regardless of whether I think it's a good idea or not. But I do think in idealized patients, Prasugrel is really a good agent. We know that from the Triton trial. So I obviously wouldn't use it in the prior stroke or TIA. That's still a black box warning. But in patients under 75, I think the 10 milligram, the 60 load 10 milligrams, a great dose. In over 75, I wouldn't do that. If I were going to use it, maybe I'd use 5 milligrams a day as the maintenance dose. And in folks that are underweight, I wouldn't use the 10 again. If I were going to use it, I'd use the 5. But with those dosage modifications, yes, I think it's a really good agent. It's, once a day. That can be an advantage in many circumstances for patients that don't like twice a day drugs or just don't feel that they're going to remember that a second dose. And dyspnea isn't a problem with it. So there are definitely some advantages to it in some patients. I still tend to favor Ticagrelor just because of the PLATO trial and that risk reduction in cardiovascular death that was significant, about 1 patient in 100 less likely to die in that trial with Ticagrelor versus clopidogrel. That's not been shown with Prasugrel so cleanly. I mean, if you look at the STEMI patients at 30 days, there is a mortality signal in favor of Prasugrel versus clopidogrel, but you really got to dig deep to find that. So if cost isn't an issue, I still tend to favor Ticagrelor. But if I get that call saying, hey, the patient's going to be stuck with a huge copay, Prasugrel, they won't in their plan, then I say, okay, fine.
So we have a question regarding, this is from Dr. Garoni. Do you consider starting Zetia and icosapent ethyl after ACS? Do you base on LDL reduction with statin, or if you don't tolerate high intensity statin? How do you make those decisions?
Sure. I mean, in high-risk patients, like to throw the kitchen sink at them. I might not start everything at once because then if there are side effects, it's hard to know what's there. So I typically will stagger those therapies because, as you're aware, a lot of times you start a patient on a statin and then, myalgias occur many times from a nocebo effect, sometimes from an actual, physiological effect. So I tend not to start them all at once. So I tend to start with the high intensity statin if they're statin naive. Then if the LDL is still above 100, I typically bump them up with ezetimibe. And if the triglycerides then are above, in my practice, I do 135, but the labeling says 150, then I typically would start icosapent ethyl. I think it's fine to start any of those in the hospital. But again, I tend to not just start everything at once just because of concern about not knowing what might be causing a side effect. And if the patient, has something, they might just stop everything at once. Did that answer the question? I wasn't sure I heard every part of it.
No, I think it did. So so let me ask you specifically about icosapent. When do you start that? Do you start that at discharge or do you start that in clinic?
Either is fine. I mean, the way we studied it in the trial, if you want to be a purist, was we didn't take patients, with acute MI or acute revascularization and enroll them in the trial. In fact, those patients would have probably benefited even more, but we didn't actually study them. We studied stable outpatients, but there's nothing either in the label or any particular signal from the trial in terms of safety that would preclude me from starting it in inpatient. So I think if it's in the inpatient formulary, as it is not in many hospitals, but if it is in the inpatient formulary and a patient's already maximized on their statin, you're sure that somebody's checked their TSH, they're not, a drinker, there's not some, glucose that's out of control or some correctable causes of hypertriglyceridemia. If that work's been done, then yes, I would feel fine starting it and certainly encourage that. In fact, I think the advantage of starting any therapy in the hospital is it tends to increase adherence because the patient just had a heart attack. If they're getting this drug now, it must be important. So I think it's really a good idea to do it, but it's not on every inpatient formulary. And again, I wouldn't just throw everything at them at once. I think it can wait if it's a matter of them being statin naive, for example.
So the next question is from Dr. Qureshi. Should cardiologists be prescribing SGLT2 inhibitors in our diabetics with CAD?
Yeah, absolutely. I think so. If I had more time, I was going to present some SGLT2 inhibitor data because I think that too is a drug class that has to be in our comfort zone. I mentioned some of my early experiences at Cleveland Clinic with the cardiac surgeons, as well. Statins weren't quite as popular at that time, but now, and it used to be the thinking was, well, let's just let the family practitioner deal with the LDL once they're, recovered from their bypass or their stent. But now I think in good healthcare systems, nobody's leaving after a stent or a CABG without being on a statin or having a documented true allergy or contraindication or refusal to take. So, the times have really changed in that regard. I think the same thing over the next 5 years will happen with SGLT2 inhibitors, where they will become the statin equivalent for heart failure and chronic kidney disease. The data are really strong. You mentioned the two NEJM papers from earlier this week at the AHA from Soloist and Scored. That was SGLT2 inhibitor where there were really early reductions in heart failure with that approach of starting an SGLT2 inhibitor in acute decompensated heart failure. That hadn't been tested so formally before, but we found really large benefits, and it could be safely done once the patient was stabilized, of course, but prior to discharge with their heart failure. So the boundaries keep getting pushed with the SGLT2 inhibitors. They're definitely good in diabetes with heart failure with reduced ejection fraction. We showed in Soloist and Scored, even heart failure with preserved ejection fraction, a significant reduction in events if they were randomized to an SGLT2 inhibitor. Really the first clear demonstration, I think, of benefit in HFpEF of an agent. So across the full spectrum of EF, I think SGLT2 inhibitors are useful. CKD, the SGLT2 inhibitors are useful. CKD or HFrEF without diabetes, those agents are useful. So, the list of indications, including labeled indications, is growing. The list of trials is growing. So yes, I think that has got to be a diabetes medicine in the comfort zone of cardiologists. I don't think we want to just say it's for the primary care physician or endocrinologist anymore, especially as those become heart failure drugs. And now that we have data even outside of the diabetes patient, and from Soloist, that was all diabetes patients in Soloist, HFpEF data, I would say in those patients with diabetes that have any of those potential comorbidities, assuming there's no contraindication, assuming it doesn't rack up the cost too much, those agents can have high copays in some plans. But assuming all that's not an issue, yeah, I think we've got to be much more liberal in our use of those agents.
So, I want to ask one of our colleagues from the community, maybe if Dr. Schreiber, you're on and you'd unmute yourself, because, you've been always one of the early pioneers of taking whatever's evidence-based and using it in all your patients. But these are challenging drugs to use with respect to getting copay and, like getting approval and all that. What's been your experience, Dr. Schreiber?
Can you hear me, Hitender?
Yes, we can.
We can hear you well.
Well, I think I'd like to first just go off on a tangent and say that I've been using long-term dual antiplatelet agents since God knows when, since I was, I think, a co-investigator in Capri 30 years ago. And I'm very pleased to see Deepak present the data for some benefit from long-term dual antiplatelets. In respect to your specific question, yeah, I mean, I'm getting comfortable with the use of the sitagliptin type agents. I think that's extraordinarily important. I think the isocopant, I'm using that. I mean, it's, I've got a full-time nurse that works in my office and spends about half her time getting approvals for the patients. But I think the data is very, very important. And, I'm out there. I'm using these agents, and I'm very, very happy to have Deepak present such a succinct and excellent justification why we should be using these agents.
Thank you.
Thank you so much. I think there are a couple more questions for Deepak. The first one is, role of FFR in non-culprit lesion during STEMI.
Great question. I was on the data safety monitoring board for the COMPLETE trial. So I'm a big believer in those data where overall a strategy of complete revascularization in STEMI significantly reduced the composite of cardiovascular death. And really, the reduction in spontaneous MI was large and over long-term follow-up. So to me, that's a real game changer. So for folks that weren't believers in complete revascularization of the STEMI patient before, I think the evidence strongly supports it with common sense. I mean, if somebody's creatinine is 3, I might not then just go after random stuff. But for patients that are good candidates for PCI, I think in general, I would do it in a staged fashion, and you can choose to complete it during the index hospitalization or in a couple of weeks that follow. That's really up to you and the patient and their comorbidities. But I think that's the way to go. And I primarily base that on angiography, unless it's an angiographically ambiguous lesion in the non-culprit vessel. And there, I think FFR, or in general, I do IFR these days, is the way to go, and really will decrease the rates of future ischemic events in these patients, who we know are high risk because they just came in with plaque rupture. And complete shows us that even if they're getting good medical therapy and statins and everything like that, that's great, they should, but there is still an increased risk of spontaneous MI that treating those non-culprit severe angiographic or IFR, FFR positive lesions reduces that risk. So definitely would want to do it. And there's a related question here, it looks like, from about complete revasc. If it's better in STEMI, as I just said it is, likely in NSTEMI, yes, I would agree that logic applies to NSTEMI, though that's not been as clearly shown in randomized clinical trials, and possibly SIHD. How do we then reconcile the better outcome with complete revascularization in those other studies with the opposite message of ischemia? That's a really tough question. I think it's because ischemia, it's a well-done trial, but it looks at a very, very specific cohort of patients that at least in many practices isn't such a highly prevalent phenotype of patient, I'll say. I'll tell you, at academic medical centers, and I think at least at higher volume community practices, it's not that often that we're just taking patients that have ischemia, but no angina or relatively mild angina in the 2000s, and then, or at least the 2010s, 2020s, and then just saying, hey, we're going to go ahead and cath you and stent you. I mean, maybe that was occurring pre-COURAGE to some degree, but I don't think now that really is occurring so much. So, I think it's a very select population. In fact, I don't think it's out yet, is it? No, it isn't. We just saw the proofs. But, Bill Bowden and I have an editorial of a paper coming out in Eurointervention where they looked at just how many patients the ischemia trial applies to. And it's a European study, so there's no issues of, American medicine, and it's sort of, fee for service as being a potential driver of things. So this is a European study. So they're really just, doing what they think is right without so much in the way of financial inputs. And it was a really small percentage of patients that ischemia applied to. So I think the results are accurate. Ischemia per se is just one of many risk factors. So just because someone has ischemia on a stress test, that doesn't trump, for example, LV dysfunction. To me, that's more important. It doesn't outweigh that they've got daily disabling angina that sounds like the real deal. So, ischemia is just one risk factor. And in and of itself, if that's the only one, maybe it's not as bad as we thought in isolation. Again, if someone has LV dysfunction, bad symptoms, that's totally a different story. So I'm not sure it's as discordant as it seems from a distance. I think the key things are, if patients have ACS, they need revascularization most often percutaneously, but in the case of NSTEMI that's stabilized, it can also include CABG. And for patients with stable ischemic heart disease, if they can be controlled with medical therapy in terms of their symptoms and they have normal LV, just I'd say in general do that. If they have LV dysfunction and or symptoms that can't be controlled with medicines, that's the role for revascularization. So I don't know that ischemia really changes that much, other than those cases where maybe people were taking silent ischemia or mild angina to the cath lab and then stenting those folks. And I think a lot of those folks, those are the ones that don't get better after PCI. Obviously, if they're asymptomatic, they're not going to get better. But even the ones with mild angina, a lot of times, that's non-cardiac chest pain that they've got in the first place.
So, we have one more question related to GLP inhibitors in high-risk PCI.
Sure. So I was really praising the SGLT2 inhibitors, and there's some advantages to them. They're easy to dose. There are side effects that you need to know about, but the side effect profile overall is pretty good, especially as far as diabetes drugs go. GLP-1s until recently were injectable. Now there is oral GLP-1 also agonist, but I think they also should be considered in patients with atherosclerosis, including high-risk PCI. I guess in my old algorithm, I typically go SGLT2 inhibitor first, then GLP-1 agonist. Of course, metformin's there in the mix. It's cheap, it's familiar, you know, and older data suggest that it might have cardiovascular benefit also. Those are older data. I don't know how they would hold up if that were presented, say, to the FDA today. But you know, there's some evidence as well from more recent observational data that metformin's good. U.S. and European guidelines differ a little bit in terms of whether metformin should still be first-line agents or not. Oftentimes, it is still my first-line agent because of cost-related issues. But you know, really, what I think it would be good for cardiologists to be familiar with, of course, is metformin. But also SGLT2 inhibition, and I would say with GLP-1 agonist. And with that, you know, that's really, I'd say, frontline diabetes therapy these days. You know, sulfonylureas, I know they're cheap, but really there's not great evidence supporting their use from a cardiovascular perspective. They're probably safer, the ones that we have now, than ones in the past in terms of cardiovascular risk, but no cardiovascular benefit that's evident.
So thank you so much, Deepak.